Ashar sir. Ashar sir, good evening.
Good evening.
Sir, വിളിച്ചിരുന്നു.
Okay.
അപ്പം sir join ചെയ്യാൻ meeting കഴിഞ്ഞു join ചെയ്യാന്ന് പറഞ്ഞിട്ടുണ്ട്.
Just meeting കഴിഞ്ഞു. അവിടെ meeting end ചെയ്തു. ഇപ്പോ കേറുമായിരിക്കും.
Meeting കഴിഞ്ഞു join ചെയ്തു. end ചെയ്തു. Okay, ശരി sir.
കേള് അത് കേളാൻ വേണ്ടിയാ വിളിക്കുന്നത്. Okay.
Sajid sir, good evening.
Suresh sir, Mohandas sir, shall we start the sessions?
Yes sir.
Suresh sir?
1 second.
Yes, yeah.
One minute. 1 second.
Dr. Ajay.
The meeting is called.
Dr. Ajay.
Yes sir. Can you just unmute? Hello. Suresh sir, can you just unmute?
Start the meeting?
Yes sir, shall we start?
Okay. I request everybody to please stand up for a silent prayer. Thank you very much. Please keep standing for the flag salutation by Secretary Dr. Raju.
Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind.
Thank you, Dr. Raju. Please be seated. I request Dr. Mohandas Nair K, President IAP, to welcome the gathering.
Dr. Mohandas, please unmute yourself, please.
Okay. Respected Dr. Rakesh SV, President, IMA Calicut. Dr. T.P. Jayaraman, President, IAP Kerala State. Dr. Raju Balram, Secretary, IMA Kozhikode. Dr. P.M. Suresh Kumar, Assistant Director, IMA CGP. Dr. Ashraf TP, Scientific Coordinator, Saath Program. Today's speaker, Dr. Abhay Martin, Senior Consultant and Head, Department of Dermatology, Baby Memorial Hospital. Dr. Ajay, Secretary, IAP Kozhikode. Dr. Shaji Thomas John, past president of IAP Kerala, Dr. Vijay Kumar Riyam, President-elect IAP Kerala, Dr. Vishnu Mohan, State Office Bearer, IAP Kerala, other respected members, senior faculties, and dear friends. I am very happy and proud to be here in this platform with IMA Calicut. So this is a combined program of IMA Calicut and IAP Calicut. And this is Saath program. And this is the first of its kind of this year. And here, what we aim is the practicing pediatricians and the general practitioners. And we will be discussing common pediatric topics. So we are sure that this program will help the practicing pediatricians and general practitioners in having better knowledge in common pediatric problems, and thereby it will help them to have a rational practice on these conditions. So, as president of IAP Calicut branch, I am very proud and very happy to be associated with IMA Calicut branch. And both IAP Calicut and IMA Calicut are part of a national organization. And in both these associations, the branches of Calicut is having a very important place, and it is recognized. And both these branches are identified as the best branch of the nation. So this is a very, very proud moment, and this program is going to be very successful. I am very sure on that. And today we are having Dr. Abhay Martin, who is a very good academician, a successful practitioner, a good orator. And he's going to talk about common pediatric dermatological conditions. And for this program, I invite Dr. Rakesh SV for the presidential address.
Thank you very much, sir. Respected Chief Guest of the Day, Dr. Jairam TP, President IAP Kerala, Dr. Mohandas Nair K, President IAP Kozhikode, Speaker of the Day, my good friend Dr. Abhay Mani Martin, Assistant Director IMA CGP Dr. PN Suresh Kumar, Scientific Coordinator Dr. Ashraf TP, my Secretary Dr. Raju Balram, Convener of CGP Dr. Mithun Shashi, senior members of the profession, and my dear friends. It is indeed a great pleasure for me to deliver the presidential address to this august audience. And it made more added joy in that I'm a dermatologist, and this very excellent endeavor by IAP and CGP of discussion of common pediatric dermatosis and other specialties is really, I must congratulate the vision of IAP and CGP for such an excellent initiative. This is the need of the hour when people are going for more specialization of the problems. We are actually trying to take the people, take the practitioners more into the public, and more teach the specialties into the general practitioners. And that is, I think that is a much needed need of the hour. And today I'm extremely happy that this excellent endeavor of you will be the inaugural speaker is none other than Dr. Abe Mani Martin, a very good friend of mine. He's an excellent clinician, an excellent academician, and whatnot. He's and above all, he's an excellent orator. I'm sure you all have a feast. A feast of academic knowledge awaiting you coming out from Dr. Abe Martin. Let me also extend my warm welcome to my dear good friend on behalf of IMA. Welcome, Dr. Abe. And with these words, I do not wish to dwell on more time for this academic event. I'd request Dr. Mohandas Nair, I request Dr. Jayaraman TP, President IAP, to deliver to inaugurate this session and also give the inaugural address.
Respected President of, hope I am audible.
Yeah, you are.
Everybody, respected President of IMA Calicut, Dr. Rakesh SV, Dr. Mohandas Nair, President IAP Calicut, Dr. Raju Balram, Secretary IMA Calicut, Dr. P.N. Suresh Kumar, Assistant Director IMA CGP, Dr. Ashraf TP, Coordinator Saath, Dr. Ajay V, Secretary of IAP Calicut, Dr. Vijay Kumar, President-elect IAP Calicut, Dr. Shaji, past President of IAP Kerala, Dr. Suresh, past Secretary of IAP Kerala. I am very happy to inaugurate this program, which is very aptly named as Saath. This is actually this year's action plan of Indian Academy of Pediatrics, Kerala, envisages to have several programs in association with Indian Medical Association regarding the pediatric problems in general practice, to make general practitioners aware of the scientific developments in pediatrics, to take it to the grassroots level, because basically a major chunk of general practice constitutes pediatric problems, and very aptly at least 20% of the pediatric practice now consists of pediatric dermatological problems. And it is so very relevant that Dr. Ashraf and the team Calicut is kickstarting this program with a very practical problem that's a very common practice, general practice issue, that is pediatric dermatosis. And I'm very happy to inaugurate this program and wish the very best to the program Saath, as well as this today's scientific session. And over to Dr. Raju Balram, over to the chair to continue the session. Thank you.
Thank you very much, sir, for inaugurating the session. Before we go on to the academic program, for the felicitations, may I invite Dr. Raju Balram, Secretary IMA Kozhikode.
Thank you, President Dr. S.V. Rakesh. Dr. Jayaraman TP, President IAP Kerala. Dr. Mohandas Nair, President of IAP Kozhikode. Secretary IAP Kozhikode, Dr. Ajay. Speaker of the day, Dr. Abe Martin. Indeed, it's the first time I'm getting an opportunity to give felicitation for a pediatric program. And I see a lot of familiar faces. Ashraf is there. Shaji Thomas John sir is there. Indeed, it is a great initiative on the part of the CGP team of IMA Kozhikode to have bought this unique program involving dermatologists and pediatricians. Thank you very much. And IAP has done a great job. As always, they're doing a great job in Kozhikode, and we'll be having more programs. We are looking forward to more programs with you. As far as Dr. Abe Martin is concerned, I have been associated with him for at least, I think maybe since 2005, 2006 onwards, as when he had just joined as a young man in Baby Memorial Hospital, working under the legendary Dr. Sugudan sir, the professor and head, who retired as professor and head of department. A lot of things he had learned from Dr. Sugadan, and one of the best photographs that we who can see in dermatology, you will see today. And one of the best speakers you're going to hear, that's going to be today. Dr. Abhay Martin, thank you very much for having taken time off your very busy schedule. I'm really looking forward to this session today. I wish you a big welcome, though I'm not a part of the welcoming committee or anything like that, but still I'm looking forward to your slides. Thank you very much for having taken time off your busy schedule. Thank you, IAP. Thank you, CGP, for organizing this great meet. I think it's a clash of the titans. Thank you very much. And over to you, Dr. Rakesh.
Thank you. May I request Dr. P.N. Suresh Kumar, Assistant Director, IMSCG, to address the gathering.
Hello, am I audible?
Yes.
Respected dignitaries of IMA and CGP and Indian Association of Pediatrics, Kerala State Branch. IMA, CGP.
Dr. P.N. Suresh Kumar.
Yes, am I audible?
Yes, you're audible.
Yes.
Yeah, this is our 5th academic program of IMA CGP Kozhikode during our time. So this time we are joining hands with the Indian Association of Pediatrics Kozhikode branch. And I think the Kerala State branch, they are very well organizing their one of the awareness program, especially for general practitioners. And I think it is under the supervision of Dr. Ashraf. It is a Saath program. So we are very happy to join with IAPP for our today's academic program. Today's program is, I think this will be very useful for the general practitioners, because every day they will be seeing one or other patients, pediatric people with dermatology problem. So I think this will be a very good academic feast, which is coming from jointly from IMA CGP and IA, Indian Association of Pediatrics. We have got a very good eminent speaker, as Dr. Raju Balram mentioned. We have got a very eminent speaker, Dr. Abhay Martin. He is the senior consultant and head of the Department of Cosmetology. So we are expecting for a very good academic feast from our very good speaker. So once again, I am thanking the speaker, all the organizing team of IAPP, as well as I would like to thank all the audience, and we are expecting a very good academic feast. Once again, thank you all, JIMA.
Thank you, sir. May I request Dr. Ashraf TP, the brain behind I'm sure he is the brain behind the program, the scientific coordinator of the Saath series. Please offer your felicitations, sir.
Thank you, Dr. Rakesh. Chair of the session, Dr. Rakesh, IMA President Kozhikode. Chief guest of the day, Dr. Jayaraman, State President, Indian Academy of Pediatrics, Kerala. Dr. Mohandas Nair, President IAP Kozhikode. Dr. Raju Balram, the Dynamic Secretary of IMA Kozhikode. Dr. P.N. Suresh Kumar, Assistant Director, IMA CGP. Other Dr. Ajay, Secretary IAP Kozhikode. Dr. Shaji Thomas John, past State President of IAP Kozhikode. Senior members of the IMA as well as the IAP. As Dr. Jairam sir rightly pointed out, the main objective of Saath program is to empower the basic pediatricians. We will have a series of sessions to empower basic practitioner, not pediatrician, basic practitioner. We all know in our casualty, in our government hospitals, in our clinics, the basic practitioners are seeing the patients, and 20 to 25% of them, in some cases up to 1/3 of them, belongs to pediatric age group. So empowering them with the new knowledge is an important objective of this program, and we are very happy to associate with Indian Medical Association, the mother body of all of us, to implementing this program. And I'm sincerely thankful to the office bearers of the Kozhikode IMA, Dr. Rakesh, as well as Dr. Raju Balram, for the excellent support given by them to organize this program. Definitely, we will have series of sessions. Today, the excellent speaker, Dr. Abhay Martin, will tell us about the common dermatological issues in the pediatric practice. To save time, with his words, I thank Kozhikode IMA for associating with IAP Kozhikode, for implementing its presidential action plan, Saath. And today is the first talk. I also thank Kozhikode IAP President Mohandas as well as Dr. Ajay for their active intervention to implement, to organize this program. Thank you all.
On to the academic session, may I request CGP convener Dr. Mithun to present his report. Mithun?
Yes, sir. Yes, sir.
Yeah, please make it short and brief.
Okay, I will go through it fast. Last month's academic program, we had 2 academic programs during last month. First was on the talk on post-COVID challenges in practice. There were 3 speakers, Dr. Chandini, HOD Emergency Medicine, Dr. Suraj, Professor of Pulmonary Medicine, and Dr. Dayanarayan, Psychiatrist. And second topic discussion was on everything about Shigella infection in connection with the outbreak of Shigella in parts of Calicut. Dr. Sheila Matthew, HOD Infectious Disease, Dr. Jayakrishnan, Professor of Community Medicine, gave the talk. Thank you.
Thank you, Dr. I request the chair, Dr. Mohandas Nair, to take over the session, the academic session. Hello?
Mohandas sir.
Mohandas sir, please unmute yourself and please take over the session for the academic session.
Okay. So today we are having Dr. Abhay Martin, who is a senior consultant and head cosmetic division of dermatology, Baby Memorial Hospital. And we have heard him speaking on several occasions. He's a very good academician, a very good clinician, and a very good orator also. So we didn't have any other option in thinking about who to present this topic because of his ability to make things very simple, to explain things very simply so that everyone will understand what he thinks. So I am inviting Dr. Abhay Martin for the talk on common pediatric problems. Dr. Abhay Martin.
Very good evening to everybody. Senior office bearers of State IAP, Dr. Jayaraman sir, senior office bearers of IMA Kozhikode CGP, as well as IMA Calicut Division, IAP senior office bearers, senior members of the profession, and my dear colleagues in the general practice and in pediatric practice. It's indeed an honor and a privilege for me to be the opening batsman for this wonderfully conceived program called the Saath program, Saath program. As it has been alluded to, probably around 30 to 30%, 25 to 30% of common problems encountered in general practice is pediatric, or more so dermatological problems in pediatrics. Very often during our undergraduate studies and in postgraduate studies, we tend to ignore dermatological signs and symptoms, or we are not trained to think on the lines of either a skin and systemic disease or a primary cutaneous problem. Only when we actually enter practice do we see these from the perspective of a dermatological problem, or for that matter, a systemic problem. And that is where I thought the general practitioners form the first line of defense, so to say, and the first point of contact with the patient. And it is necessary to make it a strong case that general practitioners are well aware of dermatological problems as much as they are already aware of several other systems of medicine, across medicine. So without much ado, I will start my presentation. I'll just be sharing my screen. Is my screen visible to everybody?
Yes, sir.
Yes, sir. Visible, sir.
Yes, sir. So I have named it as common skin disorders in children, what to do, what not to do, and some practice tips. So these are very, very basic slides which are meant to recognize skin diseases as a particular diagnosis and then treat them accordingly. Most of the skin lesions need to be recognized into a particular division. And that is when treatment becomes much easier. So thereby we can actually minimize the misuse of either a topical corticosteroid or a systemic antibiotic, or for that matter, any of the many medications that are prescribed. And more so it is relevant in pediatric practice where parents are so anxious about the skin condition, given the stigma attached to the skin problems, as well as the anxiety generally, because it is not very easy to look at a child who is weeping or who is in pain or who is itching all night. These are all very practical issues which parents face, and it is our duty to assuage their feelings as well as to give them relief. Now, it's been a very traditional myth to think that dermatology equals having in your armamentarium an antihistamine, a topical or an oral steroid, and a topical steroid agent, or a systemic antifungal agent, or a topical antifungal agent. This was the typical armamentarium. But I would like to break this myth through this presentation. Now, commonly, what are the dermatological problems which we encounter in pediatric practice or even in general practice? I think the most common of the presentations that we see in our clinical practice is eczemas. Second would be infections. Third will be a host of rashes which we see, which may be either infective or for that matter, a drug rash. Some amount of drug reactions one might see. Congenital diseases is something which might encounter far and few between. And of course, the entire gamut of skin lesions seen in adolescent dermatology, not only acne, hirsutism, or insulin resistance related or hyperandrogenism related cutaneous signs, and a new host of sexually transmissible infections which one might encounter. So I will not, due to paucity of time, I will not be going into details of all of these. I will keep part of these topics for the open house where you all can ask questions. But the common skin problems I will be alluding to. I would also add a small note on the judicious use of topical corticosteroids. Now, eczemas, as I mentioned, are the most common of the dermatological problems. Some certain general principles when we encounter a patient with an eczema is first to recognize, is it an eczema or is it an infection? Is the eczema acute, subacute, or chronic? Is the eczema endogenous or exogenous? And can you identify the etiology in an eczema? And if you have diagnosed it as an eczema, what are my do's and what are my don'ts? So this will summarize what I will be presenting in the section on eczemas. Now, as per definition, actually, an eczema is a reaction pattern of the skin. So when a small speck of dust gets into the eyes, the immediate reaction is to become erythematous, itchy, and start oozing out tears. Similarly, the skin actually becomes erythematous, edematous, and then starts forming small vesicles, and then those vesicles rupture and ooze out serum or blood, as the case may be, and then you will see crusted reaction, and finally the eczema makes its presentation. So that is a presentation of a characteristic acute eczema. So therefore, all eczemas are reaction patterns of the skin. It is characterized in its acute stage by erythema, edema, vesiculation, oozing, and crusting. That is what I have shown in the photograph on the right. And in its chronic stage by lichenification. So what is meant by lichenification, I will show in the next coming pictures. Now, infections can also resemble an eczema, and eczemas can become secondarily infected. So it's necessary that we know, are we dealing with an eczematous response to an infective agent, or are we dealing with an infection which has gone in for a eczematous response in response to that particular organism. So these two terminologies we do use: eczema with secondary infection or an secondly infected eczema. So what I mean to say is, suppose a person has come with a contact allergy to a footwear, and once there has been an eczematous response and there is oozing and crusting, that can secondly get colonized by staphylococcus, and that staphylococcal infection, the body might throw an exaggerated immune response which further aggravates the eczematous process. So here you have a primary contact allergic eczema which is going in for a secondary infection. The other way around is also possible, wherein you will have a primary infection. Like for example, you have a staphylococcal or a streptococcal cellulitis or an erysipelas, which breaks down and the body throws an immune response against that particular bacteria, and you find an oozing with vesiculation, and the thing ruptures and produces an eczematous response. Ultimately, what we are trying to identify here is that there is an eczematous process going on, and what is our strategy to manage this patient when the patient presents in this fashion. So these are 4 different photographs of how a simple eczema got exacerbated once the patient went in for an alternative system of medicine. This was a presentation to my clinic. What you see here is, this is an edematous limb, and there is an area of erythema all around, and one can also see that the skin is eczematized or exfoliated completely. You are able to visualize small pustules, which means there is a staph infection, and you can see oozing and crusting, which means the vesicles have ruptured, the staph vesicles have ruptured, and you can also see the vesicles, small honey-colored vesicles on the soles of the feet. So it is present on areas where the contact with the footwear has occurred. So this was primarily a contact allergy to footwear, which was actually missed. The avoidance of the footwear was not advised, and then this child was taken to a homeopath and then finally ended up with a secondly infected process. So if it is bilaterally symmetrical, one would have to think of a footwear. It's a very one example which I'm giving you of a contact allergy which has gone in for an eczematous process and finally a secondary infection. So here, when I see such a patient, first and foremost, I need to recognize it's an eczema which has actually got secondly infected. So I have to treat both the eczema and I have to treat also the infective process. So here I'll be using both an antibiotic systemically. I will also look for a lymphadenopathy, in this case, regional lymphadenopathy, whether there is fever, and if it is not responding to local antibiotic therapy, then I need to go in for a systemic antibiotic. So these are the 3 indications where I will use a systemic antibiotic. Now, as far as the eczematous process is concerned, I will be using saline compresses, which will actually reduce the inflammatory process. It will, by its osmotic action, it will remove out the excess fluid which is draining out, and it will also reduce the edema, and thereby the inflammation subsides and the eczematous response will subside. This is not a case where I should be using a topical corticosteroid inadvertently too, because this is going to worsen, the staph infection is going to worsen and then lead on to a cellulitis. So the judgment that you should use only a simple solution as a salt soaks, and then apply a topical antibiotic, which in this case may be either a mupirocin or a fusidic acid, and then ask the patient to be brought back another 4 or 5 days later after you've given a course of antibiotics for 5 days, and then treat the eczematous process. So the infective process gains preeminence over the eczematous process. So this is how one would tackle this particular case of an eczema. Now, characteristic of any infection would be, the staph infection would be the impetiginization. So when we see honey-colored crusts on top of these lesions, one has to think of a secondary staph infection. And you would also notice that these small vesicles are forming in and around here. Small papillary eruptions are forming in and around here, The whole skin is a little glazed, which means it is edematous. And you're also seeing scaling because the skin has desquamated. The epidermis has desquamated because of the inflammation. And you're also noticing the honey colored crust. So which means that this is primarily, it was an impetigo. So it has to be treated as an infection first. And this secondary vesicle formation is secondary to the primary infective process. This is what I was referring to here. The second case is actually an infection, a simple pyoderma, which was actually treated with a topical corticosteroid, and it got worsened to lead on to an eczematous process. So this recognition is equally important. So these are two cases where a topical corticosteroid should not be used at first instance. Now, the second thing which I wanted you all to recognize is it an acute, a subacute, or a chronic eczema? So all three photographs I've shown here. An acute eczema will be weeping. It will have oozing, or vesiculation may or may not be present when the patient presents, depending upon when the patient presents. And you will also find small eroded lesions or crusted lesions. So this will give you an indication that's an acute eczema. A subacute eczema, on the other hand, will have dried up a little bit, and then you will find slightly erythematous areas. So this may be a presentation, say for example, in a condition called nummular eczema. You may not actually find total oozing coming out always. Patient might present to you at this stage. The third is the chronic eczema, where you see a lichenification. I had earlier referred to the term lichenification. The term lichenification has three components to it. The first component is hyperpigmentation. Second is thickening of the skin. And third, you will see increased skin markings. See, the normal horizontal skin markings are exaggerated in this area. This particular patient is having a psychosomatic illness or a psychocutaneous disorder called neurodermatitis or lichen simplex chronicus. This young girl of around 17 or 18, that's the usual age when we get this, when they are really frustrated, when they have a lot of anxieties, and they tend to self-inflict injury or repeatedly rub the dorsal of the foot, leading on to a lichenified skin. So these three presentations can easily be recognized if we know the morphologic patterns of these diseases. So this I have spoken to earlier: erythema, vesiculation, oozing, and crusting. And chronic eczemas will have lichenification, which comprises of hyperpigmentation, thickening of skin, and increased skin markings. Now coming to, is the eczema exogenous or endogenous? Now you have diagnosed it as an acute, a subacute, or a chronic eczema. Now you have to ask yourself whether it is a exogenous or an endogenous. So you should know which are the exogenous and which are the endogenous eczemas. The exogenous eczemas comprise of only three things. Either it should be an irritant contact eczema, an allergic contact eczema, or a photosensitive eczema. The endogenous, on the other hand, may be an steatotic eczema. Steatotic means arising because of dryness of the skin. Steato means fat. Steato means loss of fat, or the sebum layer is completely lost with the skin. Atopic eczema, which is similar to an atopic rhinitis or an atopic conjunctivitis or an atopic asthma. As part of the same spectrum, you can also get dermatitis, which is called atopic eczema. Then the third would be stasis, which is usually not seen in pediatric, more often seen in elderly. Neurodermatitis, which I showed, the chronic eczema, and seborrheic eczema, which you can see in the neonates as well as in slightly older age group. Until the age of around 1 to 1.5 years, one might find seborrheic exacerbation because the maternal androgens are there acting upon the child's skin too. So these are the exogenous and endogenous eczemas one might encounter. So once we diagnose that, so this is a classical case of a irritant contact eczema. I'm just showing you representative photographs because of paucity of time. So what you see here is actually this child has actually gone and played in a place with a lot of vegetation. So it's usually when it goes and plays in the playgrounds or the grass fields. So these are small rashes which are linear and streaked out rashes. It's almost like it's been streaked on the legs. So this suggests that the child has actually come in contact with a plant, and that plant has actually caused streaky lesions, and that plant extract contains a vesicant, which is an irritant, and that irritant has caused this blistering reaction. So when you see these small, minute vesicular eruptions and they are streaked out in a linear fashion, think of a phytocontact, and more so in the exposed areas. The legs are commonly exposed areas. So it can cause an acute blistering reaction. So here all that is required is that you give saltwater compresses, and you can give a topical corticosteroid because there is no sign of secondary infection. So that will take care of the irritant reaction, because the reaction is a inflammatory response to the of the body to that particular vesicant or the irritant. Another common condition which we see is called blister beetle. It's also called Pediatric dermatitis. It's a small insect. So it gets attracted by sun light, and it's usually nocturnal. So you can see it in the seams of clothing, or you can see it on the bedding or the pillows. So these children, sometimes they may be sitting late in the night during exams, and they keep their windows open for fresh ventilation. The insect lands on the study table or on the bedding. They lie down on that, they crush the insect. So when the insect is crushed, it releases a vesicant fluid, and that fluid is called cantharidin, and that causes an irritant reaction. So when you see lesions like these, which are extremely erythematous with the small areas of vesicles or blisters, and the patient complains that it has happened all on a sudden overnight, and the patient is having regional areas of involvement, and when the patient has a burning sensation, one has to think of a Pediatric dermatitis. So this is an irritant eczematous response. This is a child actually who had a blister beetle or a Pediatric dermatitis. The irritant was actually rubbed by the child on the face, and that is how you get this. This usually desquamates very easily without even leaving a trace. So here children and their parents are very anxious about the condition, and they end up worrying about it, applying lots of irritants further. There are some parents who apply toothpaste, tea powder, lots of indigenous home remedies are applied, and worsens the whole problem. So here all that is required is to soothe the acute condition and treat. Very rarely do you need to use a topical corticosteroid here. Yet another Pediatric dermatitis where the insect was caught in the axillary region. Probably it was lodged in the seam of the clothing. So these streaky sort of lesions should make you think of a Pediatric dermatitis. Or this is an irritant dermatitis which has this child had actually a hypopigmented patch on the cheek. Somebody asked her to use slake lime, and then ended up with a strong irritant reaction on the cheek. You can also develop allergic contact dermatitis. So the difference between irritant and contact is irritant usually is a single contact is sufficient, whereas an allergic contact requires repetitive contact. That means the first contact will produce a sensitization, and the second and subsequent contacts produce more and more severe reactions. So the first time the plaster is applied, one may not get a reaction, but the second and the third day when the plaster is applied, more and more small microvesicles form at the site of the plaster. So here it is only a vesicular reaction, but sometimes these vesicular reactions can be severe. Maybe another day when the child has been brought for a dressing, you might see a very severe bullous reaction and along the sides of the plaster. So that's a more severe reaction because there is an immunological memory involved there. Similarly, one can find allergic contact to earrings. So most of these earrings which are bought in the beauty shops, they comprise of either nickel. So nickel can be the allergic sensitizer, and nickel earrings can bring on the sensitization and produce an eczematism. So initially when the child wore the earring, it would not have caused a reaction. It would have caused a little bit of erythema or redness. And then over a period of time, about a week or two, then the child starts actually developing the allergic contact eczema. This is actually an irritant. This is an adult actually who had eardrops. So each day he was applying eardrops, he started developing erythema and edema. Unless that history came out, one would not. So I've just given you an example of varied presentation. It's quite often the norm is these days to use sticker bindis. Some of them develop allergies to the adhesive which is used in the sticker bindis. Similarly, nail polishes of very poor quality can sometimes cause an allergic contact dermatitis to the dyes. And nail polishes can also be recognized when there is an irritant allergic contact eczema occurring on the upper eyelid, because when you rub the nail on the upper eyelid, so this upper eyelid has a very thin skin, and therefore the allergen tends to lodge there and then cause a allergic contact dermatitis. So very often one recognizes that there's an eczematous response unilaterally, then one has to suspect that probably it could be a nail polish reaction also. Fabrics. Very often, most of the uniforms which are given by the schools or which are polyester blended, they have, most of them are dark colors, and they tend to leach out the dye which is used. Or sometimes there are agents which are meant as a permapress, or something which does not require much of ironing, anti-wrinkle or wrinkle-free. Formaldehyde is added into the fabric, and sometimes that can cause. So unless you strip the patient and see the pattern in the form of the fabric, one would not be able to recognize this as an allergy to the fabric. Footwears are plenty. They are available in all sizes, shapes, colors, and types. Children are at a fancy to buy new ones. So if they are of a low quality, they tend to leach out a lot of these chemicals and cause allergic contact dermatitis. So when it is bilaterally symmetrical, it is fairly easy to recognize it. So ask the child how many pairs of footwear the child has, and ask the child to actually try out different ones, and then you would be able to recognize. So parents should be a party to the identification of the culprit, because very often in allergic contact dermatitis, the essential thing is to identify the culprit. Photosensitive eczema we recognize when we look at the pattern which is on the photo-exposed areas. So when we say photo-exposed areas, we mean the dorsa of the hands and the dorsa of the extensor aspect of the forearms, which is the exposed parts. This we often see in a lot of youngsters who ride bicycles or two-wheelers. And we also notice in school-going children who go out into the during the PT period and come back with photosensitive dermatitis. Some amount of contribution may also be occurring from the fragrances in the soaps, which act as sensitizers. So it is essential in such presentations that you tell the parent that minimize the use of soaps and abrasives, because when they see the child itching, they tend to think that you have to cleanse it. And it is because of lack of cleanliness, and they use a lot more soaps and a lot more irritants, and they use even abrasives. And there are some parents who are so very particular about using ingredients irritant like Dettol, which can further aggravate, and it is also a photosensitizing agent. So it is necessary that we recognize this, that it is a photosensitive dermatitis. A photocontact eczema in some children may also be drug induced. It may be an inadvertent indigenous medicine which may have been given by the parent, which they don't take into account, or it could be a drug which has been given for a particular disease. Say, for example, a child with a nephrotic syndrome was given, or hypertensive nephropathy was given a diuretic, and that diuretic may be the one which may be causing a photocontact allergy. So it's necessary that you take a very detailed history to identify the cause of the photosensitivity. Now, this is an area which is increasingly gained a lot of attention. We are finding a lot of atopics, probably a lifestyle change disease, because we are seeing a lot of Western diseases landing into our so-called developing and underdeveloped nations. One of the diseases which has tremendously increased in percentage is atopic eczema. So all of you all know that atopic eczema is a hypersensitivity reaction. It's an inherited hypersensitivity reaction. Very high IgE levels will be seen in such children. So they can either present with atopic rhinitis, atopic conjunctivitis, atopic asthma, or atopic dermatitis. So it is essential when we see children with the atopic dermatitis to ask for the history, family history of either a rhinitis or a conjunctivitis or an asthma, which might give a clue that it may be an inherited disorder. And these children have a very weak epidermal barrier, and therefore the barrier breaks, the staph infection increases, and the body's response to the staph causes a super antigen response, and that superantigenic response causes breakdown in the skin and recurrent eczemas. This is very traumatic to the children because it's very difficult to identify the trigger in these children. Some children get it when it is, the skin is dry. Some children get it in winter season. Some children get it in summer season. Some children get it with certain types of foods. Some get it with certain types of clothing, like woolen clothing, or some children get it when they are stressed out, like just before examinations. So there are a host of factors, and they are denied a lot of the usual small joys like a chocolate or nuts or pulses or meat. So these are very often denied as part of the dietary exacerbations. So it's necessary that we recognize atopic eczema very quickly and early enough, because atopic eczema can be recognized as early as 3 months when bilaterally symmetrical eczematous patches are seen on the both sides of the cheeks, or it can be in the form of a flexural eczema. So the initial first 6 months to about a year may be the presentation when the first presentation may occur. Then the second pattern of presentation would be exclusively flexural involvement in the cubital fossa, in the neck, or it can be in the axilla or the groin. So these are all presentations of flexural eczema. Flexural eczema would suggest that it is probably an atopic eczema. So that is the pattern which continues later into life. Around 60 to 70% of kids get slightly better around about puberty, and there is a significant number which also goes into atopic dermatitis into adulthood. The adolescents are the ones who are maximally affected because they have body image issues. When they are atopic, they are sidelined by their friends, and they find it very difficult to gain acceptability. And their parents are become very stringent, and they find it difficult to party. They find it difficult to interact. They have oozing lesions always. So a lot of psychological support is required when you see an atopic patient. These are a few pictures which will actually help you to identify an atopic. This is what I was referring to, the eczematous patches on the sides of the cheek. Now, this is something which I have taken as a photograph, a biscuit in hand. Biscuits contain refined flour, usually wheat flour. So this is a gluten, which can be a sensitizer, and it contains a lot of preservatives to prevent it from getting decayed. And that can actually alter the microbiome within the gut. And the gut is considered a very important aspect of immune sensitization. And that is why a lot of these children may actually be getting exposed to synthetic packed food substances, which may be worsening and increasing the incidence of atopic eczema, or even the modern day lifestyle may be one of the reasons why. So that is actually the hygiene hypothesis which is mentioned. But having said that, we don't have proof for a hygiene hypothesis, but the incidence is definitely rising in India, and more so in Kerala, which has adopted a lot of the advanced or developed countries' lifestyle. These are other presentations of the same child. You can see. So this is a child which is less than 1.5 to 2 years, and that is why you can also see eczematous patches on the trunk and on the face. This is a classical atopic eczema on the cheeks. Yet another one. And this is what I was referring to as the flexural eczematous patches on the cubital fossae. And repetitive rubbing has actually led on from this stage, the acute or a subacute stage, to a chronic stage where you see lichenified lesions here. So you can see that there is increased skin markings, there is pigmentation. So it is going in for a chronic stage because the child is constantly rubbing this area, and there is a friction from both ends of the arm and the forearm. So this can very often break down to again go back to acute. So that is what we call as an acute exacerbation of a chronic eczema, just like you have an acute exacerbation of a chronic asthma. So these areas may intermittently ooze or intermittently become erythematous and eczematous. A more florid case of an adolescent with an atopic eczema, recurrent breakdown of the skin causing these erosive lesions. This is something which we have been encountering more often these days in atopics, what we call as juvenile plantar dermatosis. It almost looks like psoriasis of the palms and the soles. You can see erythema, fissuring, and scaling of the soles of the feet. This is an eczematous response to an unknown antigen. Some have thought it is a footwear, some have thought it is the alkaline soil. But anyhow, remember that most of these patients are atopic or have an atopic diathesis, which means that these people's the epidermal barrier is very weak, and you can see this margin here. The epidermis is getting peeled off. And once this epidermis peels off and there's an inflammatory response, it produces this sort of a reaction. Now, coming to the management, I have shown you an overview of how eczema is present. I've taken an extra few minutes on eczemas because it's something which is very commonly mismanaged. So just like we talk about asthma, we talk about epilepsy, we talk about routine problems which can be mismanaged and unrecognized. So this is eczemas is something which I thought general practitioners should be aware of. So the first and basic principle is soothe the acute and wipe the chronic. So if it is an acute lesion, it's angry red. So you have to soothe it by using cold saline compresses or warm saline compresses, as the case may be. Salt water compresses are good enough. If the child or the child's parents are not much of the affording group, do not give high-end antibiotics and then waste their money on that. Just simple saline compresses, and when to use an antibiotic and when to use a topical steroid is a judgment I hope you'll be able to make now. Only if you see a secondary staph infection and an edematous response or a cellulitis-like response with fever or lymphadenopathy, then and then only use a systemic antibiotics. It should be okay to use a simple saltwater compresses. And if it is dry, you can always use a potent topical corticosteroids. So these two principles one should remember: soothe the acute and wipe the chronic. If it is dry, wet it. Like the one on the right, if it is dry, wet it. If it is wet, dry it. So these are two principles which will actually be a guide for you to manage eczemas. Commonly done problems, so do's and don'ts. Do use saltwater compresses. You can use dilute potassium permanganate, but make it a point to have dilute potassium permanganate in your outpatient so that you can explain how it is to be done. It should be very, very diluted, light pink in color, so that these mothers don't go and burn their children, because it's a strong irritant if used strongly. Antihistamines, topical corticosteroids should always be mid-potent or lesser. Never use very potent ones like your tenovate or lobate on a child. As far as possible, use very, very simple low-dose topical corticosteroids. Antibiotic, as I mentioned, these are the three main things where you should use antibiotics: fever, lymphadenopathy, abraded skin, or if it is purulent. Do not use moisturizers on acute weeping eczema. Never use a moisturizer, because it's going to occlude and the body is trying to pour out or boil out. Eczema means to boil out. So if you're using a moisturizer, you're actually occluding it and it is not allowed. So it worsens, the eczema worsens. So never use a moisturizer in an acute weeping lesion. No calamine if it is oozing. Calamine is something which is very effective for itching, but never use calamine if it is oozing. Avoid potent topical corticosteroids and avoid combinations with gentamicin and neomycin. They are well known to cause irritant reactions. Chronic eczemas, always do wet compresses. Without saline, without salt is good enough, because you're trying to keep it hydrated. Topical steroids you can use with salicylic acid or without salicylic acid, as the case may be. The classical picture of lichenification which I showed, you will have to use salicylic acid. Whether to use 3% or 6% is a judgment which you take based on the thickness of the lesion. Mid-potent or super-potent, and if you're using super-potent, use only for a short period of time of around 10 to 14 days, because there is an absorption from the skin in children which is much, much higher than in adults. So they go in for a HPA axis suppression. I'll show you a photograph of an individual who's had an HPA axis suppression because of chronic steroid abuse topically. So then you should use antihistamines, because it is the itch which causes the eczematous response. Moisturizer used generously, and you can consider something called occlusive therapy, where the topical medication is applied and on top of it a roll of occlusive film like a cling film is applied on top of it to keep it hydrated. Sometimes we might go in for intralesional triamcinolone. That's a judgment which we take as dermatologists. So as a general practitioner, it is necessary for you all to recognize that it is a chronic eczema, and this requires to be managed in this fashion without much of difficulty. Never use excess salt. When you use excess salt, it causes dryness, and already the patient has a dry skin, it will worsen. Do not blame them for scratching, because very often we listen when we tell parents it is because of repetitive rubbing and scratching the child, the first thing, doctor that is impossible. It's a basic impulse which we cannot. So what we need to do as doctors or practitioners is to give them solutions which will reduce the itching or the scratching. So give an antihistamine, a sufficiently generous dose, and also give local soothing compressors which will help the child to. So wet traps would be very good. Now coming to infections, the segment of infections will have 4 components: bacterial, viral, fungal, and parasitic. These are the 4 infections that we see. Fungal infections are the most common conditions that we see in clinical practice. And it is necessary that every general practitioner, every person who is passed his MBBS should know how to manage a fungal infection, because it's one of the most ill-treated and mistreated condition. Misuse of topical steroid going on around entire India. And we have a lot of resistant fungal infections coming up. So now it has become so bad that the fungus does not respond even to itraconazole, which was a reserve drug. Now, people have started using voriconazole and higher end posaconazole, which is very, very unfortunate. We don't need to use any of these if we judiciously explain to the patient why the fungal infection has occurred and what can be done to prevent it. So when you encounter a suspected fungal infection, these are certain salient points. Detailed history, whether the child is in the hostel, whether any other person in the family is infected, whether this was brought in by a particular relative. So when did it start, how the progression was a topical steroid applied, whether they went in for any indigenous medications, then strip the patient and see, because most of these adolescents will not show their private areas. So it's your duty to strip the patient and see whether there's a growing lesion, because they might say that they have a rash here, which might look like a suspicious fungus. So one tends to think it's an allergic eczema and then give the topical steroid and send the patient away. You have to specifically ask whether there is a lesion on the groin. A little bit of hesitancy from the child, immediately strip the patient and see whether there is a lesion on the groin or in the inframammary area, as the case may be. Ask for, again, family history. Ask for hobbies and sports, because it's now fashionable to have tracksuits and jeans and innerwear which are figure hugging, and they sweat it out. So when you start sweating it out, there is a lot of sweat and maceration which is causing an aggravation of the fungal infection. Footwear. Sometimes certain footwears can be the cause of the tinea pedis or fungal infection of the dorsum of the foot. So very vague presentations may be there on the foot, which may not be recognized as fungal infection. And when you find something unilateral and when their interdigital involvement is there, ask them the history of what type of shoes or occlusive footwear they're using. That may be the cause. If you avoid that, that might actually. So lifestyle modification is very, very important in managing resistant fungal infection. And soaps and abrasive use. Invariably, any skin problem, everybody is advised thoroughly clean it. It's because of lack of hygiene. It is not the case. There are very few skin conditions which are cross-infective and which is because of lack of hygiene. Most often it is a break in the skin barrier, and which is worsened by soaps and abrasives. That is why most of us dermatologists ask patients to avoid soap or abrasives. So when we say suggest do not use soap, they say because that is even worse, because it further degreases the skin. So what we need to do is educate the patient that this is not a permanent thing. Because the child has an eczematous response, because the child has a particular problem, that is the reason why we are asking you to hold back soaps and abrasives, so that the use can be minimized and the epidermal barrier can be restored. Allow the skin to come back to normal, and then we can always start using. So these are a few of the next few photographs will show you the different presentations of tinea which we are encountering, very florid tinea which we are encountering. Unless you strip the patient and see, you would not be able to see. Geographic lesions with a margin. This is the margin of papillovesicles that you see with a central clearing. The central area is getting cleared, and the periphery margin is there. So this is a very easy case of a tinea corporis. Similarly, one would find where the belt is actually tied. So you would find a lesion around here, or in females, it may be where the skirt is tied or jeans is tied. So this is the waist area is a very common area. So as I mentioned, children may be having lesions only on the face. They may be complaining of a chronic itchy lesion on the face. You see only the face and then you say that it is probably an allergy, and then you give a topical steroid. The topical steroid inhibits the fungus, the itching is gone, and this patient comes back with a very florid manifestation. And invariably around 60 to 70% of cases that I see, the earlier general practitioner or the pediatrician or the physician has not examined the groin or the buttock area. And that is why I miss it. So this child had actually lesions here. So that is why I took this presentation. So the child had been going around with a tinea faciae, and the child was never examined by anybody for other areas. So examine the other areas. This may be a foot lesion which the patient is coming with. You see the marginated border here. Think of a fungus. When in doubt of a fungus, do not give a topical steroid. Just give an antifungal. Ask them to come back after 10 or 15 days. If it responds, it is a fungal infection. If it doesn't respond, then think of an eczematous response. That is my dictum. So first and foremost, never use a topical steroid unless you're sure that you're using a topical steroid for an eczematous response. So this is actually a topical steroid modified tinea, which this child was using, topical steroid given to his relative. The ear is very often a site for even tinea infections. So this may be a very vague rash which you see here, but this is the advantage of taking a photograph. When you take a photograph, you can actually examine it closely, and you can see that the lesion has a marginated lesion, and topical steroid has been applied, and therefore the signs of inflammation are very less. So more presentations of tinea, and this is worsened here because of the use of soaps and abrasives. There is maceration occurring, and sometimes even oozing can occur. This is hardly recognizable as tinea. It's just a vague hypopigmented patch which you see. But very carefully observe the morphology here, and it is actually a geography map-like lesion here. And this child needs to be examined entirely, and you will find that the child has been applying a topical steroid given by either a general practitioner or a physician. Now, this is something which I want to highlight and tell you all again and again. Think of tinea first. We used to say think of scabies first. Now it is think of tinea. It has very, very varied presentations, which even experienced dermatologists find it difficult to diagnose as tinea. So think of tinea on the top of your list when you see. Tinea versicolor, which we used to see as hypopigmented lesions here and there, now we see florid lesions because everything is polyester, everything is figure hugging, everything is completely body hugging. Lifestyle has changed, a lot of sweating, a lot of metabolic syndrome being seen. So general resistance has come down, and diabetic population and pre-diabetic population is on the high. Insulin resistance is on the high. So you are seeing a lot more fungal infections coming in the picture. So always also look for underlying disease, like maybe you might recognize patient with a recurrent tinea versicolor or recurrent tinea. Think of diabetes, type 1 diabetes, think of thyroid illnesses. And it may be something very, very innocuous, like the child is on steroid inhalers for a very long time, or an oral steroid for intermittent asthma. And this child has developed a tinea versicolor, which is not going. So the child runs from dermatologist to dermatologist, a physician, a pediatrician, or general practitioner. Everybody gives something as an antihistamine, but nobody thinks that this could be the cause for the HPA axis suppression. So intertrigo is something else which we often see, which is mismanaged. That is why I have taken this. This is a typical presentation of intertrigo, where you see it in the groin. But these small satellite lesions here, this will give you an idea that it is probably a superadded candidiasis. Now, there is an erosion in that area. Frictional erosion has occurred and maceration has occurred, and spillover lesions of candida have taken place. And that is why you have this presentation. You can also see it in children, most often in areas where there is sweating. So this should, in such a presentation, one should never advise anything irritant. Most often, parents use a lot of soaps and the child wails in agony because it's like applying salt on a wound. So soaps contain alkalis, the child is really going to be affected by it. So they go in for more and more cleansing measures. On the other hand, you have to soothe the acute. So it's an eczematous response to the fungal infection which has occurred because of sweating and maceration. It can sometimes be a sign of atopy in certain individuals because we have flexural eczema, which may be going in for a secondary fungal infection. So I mentioned anxious parents using Dettol and soap, anxious doctors using steroid-based antifungals. They want to give relief, therefore they use multiple combination, 4 or 5 combinations, topical medications. It worsens the entire problem. Here, all that you have to do is soothe with saline, avoid irritants and scrubs, keep the area dry by mopping with cotton or soft cloth. There is an ingredient called Castellani's paint, which is something similar to gentian violet, which we are using. If you have access to it, we have in our pharmacy, you can use it. Or if it is possible, use Castellani's paint. Otherwise, you can use something like a gel-based topical micronazole cream. That should be good enough. If it is not responding, you can always refer to a dermatologist. Now, Castellani's paint contains a lot of ingredients. I just made this slide. It was actually developed by Aldo Castellani. So this is actually initially a tinea cruris, which went in for an intertrigo because of sweating and maceration. Tight jeans was the cause of the problem here. And even we find it in women also. And most of these children or individuals may complain of itching on removing undergarments because there is an erosion there. And when wind sweeps, that is when they get severe itching. Foul smell, and it can also in adults, it can affect sexual confidence. Now, my approach is to take a detailed history, especially in students who sit for long times, those who are sitting and studying for long hours, those people, women who are using polyester blended fabric. Then the new hobbies like bicycling and bikes, workouts and exercise may be the cause. So you have to look for all these things when you see intertrigo lesions. Obesity and metabolic syndrome, or are you dealing with a diabetic or a pre-diabetic condition? Now, general measures would be use soft cotton undergarments, loose clothing, and identify the cause, whether it is cleansing, whether it is excessive cleansing, obsessive cleansing as we call it, or it can be occupational, or it can be hobbies. I sometimes wedge with cotton pads. This actually helps, and use cotton, preferably light colored. This is how Castellani will look. There are other indications for Castellani's paint. You can actually use it in perianal intertrigo with secondary candida. This is quite commonly seen in pediatric. Scrotal dermatitis. This is again because of repetitive rubbing. Very often parents teach them that this is a unhygienic place and therefore you have to keep it squeaky clean, and that ends up with an irritant. The skin barrier is completely removed. So reduce the irritancy. You can use it in tinea pedis, those who have occlusive footwear issues or a macerated foot. A simple KOH in most fungal infections, if you are in doubt, a simple KOH mount will help. Scrapings are taken and then sent to a lab, microbiology, and they will look for hyphae. If there are hyphae present, they'll give you the report, and then you can be sure that you are dealing with a fungal element. If you do not have a site lab, or if you do not have access, always send it to an accredited lab. The most important thing here is patient education. Without patient education, fungal infection treatment is useless, right? And you should also use the right antifungal. So preferably use antifungal alone, never with a steroid, and avoid misuse of topical steroids. Coming to pyodermas, I have mentioned about how you recognize impetigo. The honey-colored crusts are the classical presentations. You can occasionally encounter very serious sick children like with staphylococcal scarlet skin syndrome. This is a bacterial infection because of staphylococcus. The child was usually febrile, short duration of febrile illness, followed by erythema on the face, in the periocular, the perioral areas, the axillae, the groin, and the perianal areas. And the child paradoxically cries when the mother takes up the child. It should be the other way around. So this can be an evidence to say that probably the child is going in for a staphylococcus scarlet skin syndrome. Most often with a single dose of any antibiotic it responds, but it is important that you recognize it early enough, because the symptomatology is way beyond what we usually would have expected in a simple problem like a staph infection. Septicemia can occur, and therefore antibiotic therapy is warranted. So you can see presentations like perianal erosions or a perineal areas and scrotal skin peeling. So it can be presenting in any form, just as a diffuse erythema, or it can present in the form of a scaling in the perilesional areas. Coming to viral infections, there are a few viruses which affect the skin. You must be aware of that. Of the DNA viruses, the herpes viruses, which include the herpes labialis, which occurs along with fever, herpes simplex type 1, herpes genitalis. We must be aware in the pediatric and adolescent age group because of sexual experimentation. We are seeing a lot of cases of herpes genitalis. Varicella zoster, which belongs to this chickenpox, and its sister variant, which occurs more often in elderly, but also can be seen in pediatric age group. Infectious mononucleosis can present with a rash, a diffuse rash, which I will show when I deal with rashes. Human papillomavirus, HPV, condyloma acuminata, is something which we see. And again, there has been increasing demand for vaccination because of sexual experimentation occurring early in teenagers these days. Molluscum contagiosum virus, I'll show you the photograph of how to recognize that. RNA viruses, the measles, rubella, hand, foot, mouth disease, dengue, chikungunya, all of these you are very much aware of. Now, a few points about chickenpox. Chickenpox very often is easy to diagnose when there are florid lesions, erythematous, pearly, small vesicles are occurring after a prodrome of 3 to 5 days of fever, and second or third day patient comes with a vesicle, then crusts and then falls. Everybody knows to diagnose chickenpox. What I'm trying to emphasize here, an early lesion, just 1 or 2 vesicles or a few vesicles have erupted. Is it an insect bite reaction or is it a chickenpox? The simplest diagnostic methodology, probably underused methodology, is to send for a Zank smear. A Zank smear is done in most hospitals by dermatologists. The vesicle is deroofed and the base is scraped and then taken on a slide and sent to a pathology department. Within 2 hours, they will give you a report saying that it is multinucleated giant cells are seen. If it is so, then it will start the treatment for chickenpox. Otherwise, it's a waste of money to give a lot of acyclovir and valacyclovir to patients who do not have chickenpox, who may be having just an insect bite reaction. Also, if possible, strip the patient and see extremities predominantly involved, it could be insect bite reaction. If the entire body is showing rashes, vesicular rashes, think of varicella. So you have to correlate a lot of clinical findings by systemic examination. Very often parents come and ask, one child has it, can I give a chemoprophylaxis, the same medication, so that the other child does not get it? There is no scientific proof that chemoprophylaxis works. But in very special conditions, like for example, a child is going for a 10th standard or 12th standard examination, I might give 3 or 4 days, though it is not very strongly grounded on scientific basis, because individual susceptibility is different, and therefore the other children may or may not get varicella even if. Vaccination, it should be done pre-exposure. Post-exposure has again doubtful value. Immunoglobulin is to be given, but it is very expensive, not available. Subtle signs may be the presentation of herpes. So herpes zoster is easy to recognize when you see a dermatomal pattern with pain, vesicular along the dermatome. But when you see something like this, a small group of vesicles, one tends to think it is probably a pyoderma or a herpes simplex. But in this case, I had to actually open the mouth and see that it is a unilateral lesion. Vesicles are seen in the mouth. So the examination of the oral mucosa in a patient who actually presented with this, but had I not opened the mouth and seen, I would not have been able to recognize that it is actually a herpes zoster. So these are simple things. So this is actually a herpes zoster involving the maxillary division, and the maxillary division supplies the palate. I was referring to sexually transmitted infections. Viral infections are on the increase. Bacterial infections like gonorrhea and syphilis are not that seen. Syphilis is slowly coming back. Gonorrhea is not that seen, but herpes and condyloma are on the increase. That is because a lot of experimentation is taking place these days. So whenever we see herpes in a small child, think of abuse. Similarly, when we see perianal lesions with condyloma acuminata, warty lesions, think of abuse. So this is a pointer, and your antennae should be up that it is possibly a sexual abuse. Herpetic stomatitis, it's difficult to differentiate from aphthe, but do not prescribe a topical corticosteroid unless it actually warrants so much. A Zank smear can help. You can even give dilute potassium permanganate, which has an antiviral effect, or a small amount of saline cupressus, and a lot of hand holding is required because oral cavity herpetic stomatitis can be very painful. Antiviral need to be started based on the Zank smear. This is extensive molluscum contagiosum. Very often it is self-limiting. But when it is extensive and many children are being affected, we might have to remove them by enucleation one by one. But that is not often the case in such extensive lesions, because this child would need sitting under general anesthesia. We have done that, but if it is absolutely warranted, we might even go in for a general anesthesia to remove these molluscum. Hand, foot, mouth disease, again, it's easy to recognize: a short burst of fever followed by rashes on the palms and the soles, and invariably examine the oral cavity. You will see small vesicles like you see here in the posterior pharynx. So always one should have a torch, and if possible a camera. You can always zoom that and actually see this. Parasitic, all of us know about scabies, the interdigital involvement, the involvement along the circle of Hebra. That's called a circle of Hebra. You develop it in the interdigital spaces. You develop small papillovesical excoriated areas around the wrist. You can get in the inner aspect of the elbows and the axilla, the nipple area, the umbilicus, and the inner aspect of the thighs and the groin, and the web spaces of the feet. So these are all the areas where. So what should you use? Most of us now have shifted over to permethrin 5% cream. Here again, it is important to educate the patient. How to apply the permethrin? It should be applied by all members of the family. That it should be done overnight. Single application is sufficient, to be repeated after about a week, or sometimes a second application after a second week. The rest all of the older preparations we have stopped, but largely permethrin is what is now recommended. Right? So it's always better to have a small sheet which explains how the disease takes place. We have a pamphlet for scabies, so that is given to the patient at that point in time when the patient comes with scabies. So everything is mentioned as to how all the frequently asked questions are given, how the medication is to be applied, and how the clothing, how the family members, and why it should be done. So we take about 5 minutes for that particular case. Otherwise, scabies cannot be treated successfully. Now, when it comes to rashes, this can be the presentation of several diseases. Erythematous maculopapular rashes can be presentation of several diseases. So it's always, am I out of my time? I'm sorry.
Okay, sir, please continue.
Yes.
Okay. So rashes in the form of maculopapular rashes, papular rashes, or vesicular rashes, all of these have differentials. So that would be an entirely different topic altogether. But what often we find it difficult to identify, is it a viral exanthem or is it a drug rash? So few pointers which will give you that it is probably a drug rash. So viral rash will have a prodrome, even the drug will have a prodrome. Say for example, a person is going for a Stevens-Johnson syndrome, initially might present with a diffuse maculopapular rash, but later you might see mucosal lesions occurring, right? But you will see less mucosal involvement in viral, but more mucosal involvement in a drug. Less itching in viral, more itching or pain, skin pain, tenderness is seen in drug reactions. Palms and soles involvement is rare in the viral infection, except in HFMD where you see a palms and soles involvement. Here in a drug rash, it's more likely that the palms and soles are involved. Lymphadenopathy is more often seen in viral illnesses. Here it is less likely if it is drug induced, because it's an acute presentation. Temporal association will always be seen in a drug intake, right? So the drug has been taken, followed by this has developed. In the other case, you will not, it's very difficult when you see a case like a infectious mononucleosis with ampy rash, like this one. This was an infectious mononucleosis with an ampicillin rash. So it's difficult to say it's a drug rash or not. So there you would err on caution and look for mucosal lesions, ask for the drug history. Even then, if you do not have a diagnosis, then you give a conservative management and see. Only if you're sure that you are actually dealing with a drug reaction and a specific aggravation of the rash over a period of time with intense itching, mucosal lesions, mucosal or cutaneous pain, start steroids immediately. Within 72 hours, one should start steroids. Otherwise, it's contraindicated because there is always a risk of developing a systemic complications due to viremia. There's another condition which one might encounter in clinical practice, psoriasis. It's largely a dermatologist domain, but to recognize that it is psoriasis, because childhood psoriasis, one good thing is it settles very fast. And how do we recognize it? You will see erythematous or pigmented in this part of the world, we see a lot more pigmentation. We don't see actually erythema as they say mentioned in the Western textbook. So you will see a slightly pigmented, mildly scaly, and you can always use a glass slide to do what is known as the Auspitz sign. Scrape it repeatedly, you will see a lot of micaceous scales coming out, and finally small bleeding points coming out. So that is a characteristic presentation of psoriasis. So psoriasis can very well be treated because more often it is precipitated by a infection like a staph infection of the throat or strep infection of the throat. So if you treat this is the only indication for using an antibiotic in psoriasis. That is what is the general dictum, because you have to treat the streptococcal sore throat infection and the psoriasis also subsides. So when a presentation occurs like this as an acute presentation, do not rush to a topical corticosteroid. Give the, if at all you need to give the mildest of the topical corticosteroids, and use a generous amount of moisturizers. If the child is symptomatic, give an antihistamine. Otherwise, usually a short course of antibiotics with a topical moisturizer and a topical steroid of the mildest variety would be sufficient to allow this to settle down. If it is going beyond your capability to manage the psoriasis, always refer to the dermatologist. This is another guttate psoriasis, what we call as a guttate psoriasis. Guttate means raindrop, just like raindrops. So this girl actually had a guttate psoriasis secondary to a streptococcal recurrent streptococcal sore throat infection. Sometimes some children develop it with urinary tract infection in females also. So look for foci of sepsis in these conditions. Now, this segment is about topical corticosteroid use and abuse. We'll see a lot of patients ending up with chronic usage of topical steroid. This is one presentation of a topical steroid abuse. Eczematous response, which was repeatedly treated with topical corticosteroids, causing thinning, atrophy, and hypopigmentation. You can see the whitish skin, which is actual texture and pigmentation of the individual is like this. Whereas what you're seeing is hypopigmentation. The skin has become very thinned out, easily prone to injury, and it can even bleed at times. So this is something which we are seeing more often because patients don't want to go and buy another, go and consult again. So they buy over the counter, and general practitioners and physicians tend to give it again and again and again because they have to treat or they have to reduce the symptomatology of the patient. So it finally ends up with symptomatic management, not looking at the etiology of the condition. It could well have been a stasis eczema, or it could have been a contact allergy, but detailed history is taken. So you should not use a topical corticosteroid beyond around 10 to 15 days. This has to be emphasized to the patient. Stress on the use of moisturizer because they're dry lesion, and lessen the use of the topical corticosteroid. This is the child I was talking about. He is around a 14-year-old boy who has been on topical steroid for the last 5 years of his life. He had atopic dermatitis. One after the other, different doctors started giving him topical corticosteroid without stripping him and examining him. He developed striae, which was not even seen by one person because nobody actually removed it. The moment they see psoriasis, psoriasis is treated with topical steroid, you give a topical corticosteroid. His serum cortisol was as low as 1.2. And we had to actually take repeated serum cortisol levels, supplement with hydrocortisone, put him in, allow the truncal obesity to settle down. Topical corticosteroids were slowly withdrawn. He had become addicted to topical steroid. One day he stops using it and then he's really back with the vengeance. So we had to wean him out of the topical corticosteroid. So this is the other end which we see of topical corticosteroid abuse. This is actually a slide which shows how topical steroids can actually inhibit fungal infections. So this is actually a unilateral rash which you're seeing all around here, but you can see a marginated border here. This is not involved. When you see unilateral lesion, think of tinea I mentioned. This is actually a tinea which has been repeatedly managed with topical corticosteroids and ended up with a tinea incognito, we call. Incognito as in disguise. So this patient was being treated with the topical steroid. No antifungal was given. A single application of a topical antifungal with short course of antifungals, oral antifungals, and the whole thing disappeared. So if it was thought of, it would have been prescribed here. Something which is of dermatology importance, all dermatologists should know this particular slide, but I want to impose this particular slide on you all because all of you all should, who use a topical corticosteroid, should know how it is classified. because we have ultra high potent clobetasol, which is the most abused of all the topical corticosteroids. Your tenovate, your lobate, your topinate, or for that matter, you're using a 4-derm or a 5-derm or sigma-derm, all of these, they are clobetasol, which is the most potent of the topical steroids. And if you're giving it to a child for a certain period of time, you're actually ending up with inducing HP axis suppression. The second is the high topical potency ones, which is betamethasone, dipropionate, and of course fluocinamide and betamethasone valerate and triamcinolone. So these are things which are, again, your betnovate or beta-gelG, all of these, they are actually your high potency ones which you're using. Moderate potency is where you'll have the hydrocortisone butyrate and hydrocortisone valerate. So these are the ones which you should choose in children. So moderate or low potency. So never go to the high potency unless it is absolutely warranted. The lowest potency will be desonide and hydrocortisone, and what is not mentioned, because this is actually UK based, so they don't have clobetasone. Clobetasol, SOL, is the most potent. SONE, clobetasone, is the least potent. So either use a hydrocortisone or a low potency like a clobetasone, which will be not very harmful to the child, especially when you're dealing something like a less than 5-year-old child. Always prefer to use a very low potency topical corticosteroid. So this is what I was referring to. Common trade names I have just taken here because this is something which very often people tend to use, right? So go in for simple and low end potency topical corticosteroids. So when you're using on the face and the flexures, go in for clobetasone, fluticasone, hydrocortisone, or maximum if you want mometasone, and the duration should not be more than 10 to 15 days. Palms and soles you can use mid to higher potency because they're thick. So you can use either mometasone, halobetasol, or clobetasol. Rest of the body you can use mid potency like a betamethasone or a beclomethasone. Again, under the supervision, strict supervision of a physician or a general practitioner or a dermatologist or a pediatrician. It should be under the supervision, and that steroid should be regulated by you, and ask them not to refill their prescriptions without your permission. Avoid these 4 and 5 drug combinations of antifungal, antiviral, antibiotic, all of these combinations. They actually, it's like hitting in the dark. You hit it, sometimes it might hit, it may not hit, but you have given a steroid, which might modify the picture even for the dermatologist to recognize. So in summary, what I'm trying to say is, I've given you a small bird's eye view of what skin diseases are and why we require training in skin disease. If in doubt of diagnosis and if it is non-oozy, prescribe calamine lotion. That's the easiest and the simplest way to get out of a skin disease. Prescribe topical corticosteroid judiciously. Give antihistamines according to the age of the patient and the potency of the antihistamine. Giving a teenager who is going in for her 10th standard boards or a 12th standard boards as very strong potent antihistamine because she's atopic and she's not able to sleep properly, you treat her with very potent ones, antihistamines, and she goes into drowsiness, you're doing injustice to the child. So choose your antihistamines also wisely. So it's worth learning about which are the different types of antihistamines, just like I showed you for topical corticosteroids. And it's good to possess an atlas of dermatology. So this will actually help to look at the common conditions and then treat them judiciously. Small bits of training over a period of maybe about 3 to 4 months, you should be able to pick up the common signs and symptoms. I'm actually trying to project something of my own because I've been contributing to this particular, just like you all have the IAP, we have our Indian Association of Dermatology and Neurology. There's a small concise textbook of dermatology which we have brought out, which has very brief basic information for MBBS graduates and first year postgraduates. So this book may be helpful. You can procure it. It's easily available with JP Publishers. Sorry, I have to promote this, but the reason is because we want to empower the general practitioners through a proper IADVL channel. That is why I'm promoting this particular, not because I'm the editor of that, co-editors of that. Drug reactions also, there's another book which you can always go through. So thank you for your patient listening. I'm open to questions if you have any.
Thank you, Dr. Abhay Martin. It was an illustrious presentation, lot of pictures, and very easy to understand the condition. So now we can have questions.
Sir, there are few questions on the chat box. So first one, dermatitis secondary to Western type of toilet is very common nowadays. How to manage and give advice? What is your opinion?
Yeah, one, toilet seat dermatitis is on the increase for 2-3 reasons. One, as I mentioned, this is more often seen in patients with an atopic background. So they may be having other allergies. So ask that history particularly. Second, the type of irritants which are being used on the toilet seat is a very, very potent detergent which is used to actually cleanse the toilet seat. So these children have very, very thin epidermis. They go and sit on that, or they sit and play around with that. And that is how they develop an irritant reaction there. Secondly, as I mentioned, atopic dermatitis patients have a very thin epidermal barrier. And therefore, that barrier breaks off easily and the toilet seat dermatitis. So how to recognize it is put the patient in the prone position and strip completely and look for a U-shaped, almost like a closet-like, the posterior aspect of the thighs and the buttock area. If you see that, it is a toilet seat dermatitis. Having said that, even after children are put off the toilet seat, they still develop it. I have noticed that quite a number of people are developing because of frictional dermatitis. They are seated, the children are seated for a very long time with fabric material which is polyester blended. So sweat accumulates there. It is like a flexural dermatitis. So this almost is like a flexure where it is rubbing against the skin. And that is what is causing. It may not be the toilet seat alone. The toilet seat is one of the factors. So even after they move out of the toilet seats, if the patient is coming back to you and telling that it is not responding, then you need to look at other factors. So I sometimes advise cotton inner undergarments, or avoid sitting for long hours, take intermittent breaks so that that area is well aerated. And when seated, do not sit on Rexin or material which tends to induce sweating. Always sit with, we in Kerala have this good old turkey towel, which is actually put on. Most of the politicians will have a turkey towel in their cars. They're big ones. So something similar on those lines, I suggest sometimes to ask them to keep it between their thigh, posterior aspect of the thigh and the chair. So that actually avoids a lot of the friction and maceration is avoided. And the fourth thing is excess use of soaps and abrasives, because the moment they see an eczematous patch, the parents tend to ask them to use a lot of soaps and abrasives to clean that area. So instead, moisturize that area. So that will actually help. And you can give a topical steroid for maybe about a week or 10 days. That will reduce the inflammatory process. And then replace the topical corticosteroid with a moisturizer. So that is how one I would. And if there is atopy, recognize it and then identify it and then treat immediately.
Yes, sir. Thank you, sir. So one more question: how is tinea treatment of tinea resistant to topical azoles?
Tinea, topical azoles, almost many cases we are finding that they have extensive tinea, different varied forms of tinea, and the steroid modified tinea is something which is a real big problem for us, because already patient has been on topical steroids, patient is on relative immunosuppression because there is absorption. So if there is a topical steroid use, first stop that. Second, if there is a tinea which is not responding to a topical antifungal, then you may have to give a systemic antifungal. If there is a tinea which is not responding to azole group, either a miconazole or a bifenazole, change the molecule to either terbinafine, or you can use an aberconazole. So other azoles are there. So preferably you change the chemical molecule to either terbinafine or to the newer ones like luliconazole or aberconazole. So the newer antifungals may have to be used. But it's your judgment whether to use an oral antifungal or not based on the extent of involvement and non-responsiveness to medication.
Okay, sir. And sir, one more question: how to differentiate between mild tinea and Pediatric alba? If in doubt, can we try a mild topical steroid like Desonide for 2 weeks?
Yes, it's a judgment call which is very difficult to make, because the tinea versicolor will usually be punctate, small, hypopigmented lesions, multiple small ones. A solitary patch usually is a pityriasis alba. So if you're seeing small multiple pinpoint patches, think of tinea versicolor. When you're in doubt of tinea versicolor versus pityriasis alba, go in for an antifungal first rather than a topical steroid first. Because if you give a topical steroid, you're going to aggravate the tinea versicolor. On the other hand, if you give an antifungal or a simple moisturizer and it subsides, that's good enough. You're not using a steroid there. So the use of a desonide or even a umazone or any other low dose topical corticosteroids is ill-advised unless you have valid reasons for that. However, if you look carefully with the hand lens and you find that there are very fine, mildly scaly areas, then think of pityriasis alba. Whereas in tinea versicolor, if you stretch the skin, you will find the scales pop up. So which means that it is more likely to be a tinea versicolor. So these are subtle presentations which are difficult to recognize, but if in doubt, always go in for conservative measures in the form of a moisturizer or a topical antifungal rather than going for a topical corticosteroid.
So one question from Dr. Danya. Diapers in children, whether to use or not? What is your opinion?
I am an anti-diaper guy for a very simple reason. See, diapers are usually meant for single use. When the weight of the urine actually, it soaks up as much urine and then it is beyond its capacity to absorb and still the child continues to use it, that is when you get a diaper dermatitis. Second thing is the urine should be completely absorbed. So when some amount of residual urine is left behind, it actually causes urea to be released and that is an irritant on the skin of the child. And that is why the diaper tends to worsen. Secondly, very often, once you put on the diaper, the parents do not change it that frequently, especially at night, because the child passes urine at night and then goes on passing the second time also and it is still not changed. So diapers are actually safety nets for the mothers to sleep or the parents to sleep. But the child is actually suffering there because repeatedly it is passing urine. So if there is a diaper to be used, it should be used not more than for a period of 2 hours. That is what I usually tell. If at all you need to use, say, going outdoors or you do not want to soil the doctor's clinic, they say I have used it only now. But when there is an active diaper dermatitis, do not always discourage the use of diapers. Diapers are to be used very judiciously. That would be my take home. It is always better to use cloth, disposable cloth, and then remove it off because you're actually making it free, and give diaper free periods. If at home, you can always see the child is soiled and then you can always put it aside. Use it only when you are going out on social occasions. And remember, when you put a diaper and then the child is actually taken on the hip, actually there is so much of soakage and so much of contact there. So that is why diaper dermatitis is very severe these days. And our humidity laden atmosphere also. We are by the seaside. So coastal areas, humidity is high, certain children sweat a lot, and you have diapers not being changed frequently. And that is the reason why I feel diapers have caused so much of a problem. When there is an early diaper dermatitis, again, soaps come, Dettol comes, or any other irritant comes, which even worsens the area of the dermatitis.
Which antifungal to use for tinea corporis and cruris? Is cotrimazole effective?
Clotrimazole was effective. I feel, unfortunately, now we do not find effectiveness to topical clotrimazole alone. Now we have moved over to either terbinafine or the newer azoles, like as I mentioned, either abraconazole or loliconazole. Miconazole, to some extent, in small solitary lesions, 1 or 2 lesions, it does have some effect. But I think we have to move to other topical agents. The use of a systemic agent is something should always be kept in mind, because systemic agents, because of the extensive nature of the lesions, we may have to use systemic agents.
Thank you, sir, for the wonderful session. I think if you keep on, it will keep on going on with the amount of questions. I think we'll take the last question. How do we treat multiple hyperpigmented patches on face of skin of children?
Yeah. Hypopigmented patches on the skin, there are 2 or 3 conditions predominantly you have to keep in mind. One is tinea versicolor. So as I mentioned, tinea versicolor on the face in a pediatric age group is much easier to recognize because you have small punctate pinpoint hypopigmented patches which suggest that it's a tinea versicolor. Second possibility is pityriasis alba, which will always have an association with either a dry skin with an atopic diathesis, family history of diabetes, atopy may be there. So that helps to, and mildly dry or scaly patch, solitary patches usually. Third thing which comes to mind when you see a hypopigmented patch is whether you're dealing with a Hansen's disease. That's very difficult to assess on the face because sensory input is very good in the face. And when you examine the sensations on the face, you can get a very variegated response. So never utter the word Hansen's unless you're sure of Hansen's. It's better to take a biopsy and prove that it is Hansen's and then say it is Hansen's. So Hansen's disease is there, but always examine other patches. Always Hansen's is a slow growing lesion. You don't have to get alarmed. So wait it out, apply conservative measures apart from topical corticosteroid, wait it out, and then the fourth differential there is a petaloid variant of seborrheic dermatitis. So petaloid variant means it's almost like individual hypopigmentation, just like P. alba lesions, multiple you can see on the forehead and all that. If you ask for scaling of the scalp with dandruff of the scalp, there'll be plenty of dandruff on the scalp, and that can also cause P. alba-like lesions, which you can see in both atopic dermatitis and seborrheic dermatitis. So these are the common hypopigmented lesions which we see on the face. So the only thing which one should not miss is a Hansen's. That should be there on the list, but don't alarm the patient with Hansen's disease unless you're sure. There has been an important case which has gone against a physician dermatologist who actually alarmed, and they put a case for traumatic mental agony for having given empirical Hansen's disease treatment. So Hansen's and vitiligo, they have a lot of stigma attached. So when we utter the word Hansen's, we should be very clear. And because it's a face, sensory examination is not that easy. If you have a very well-defined patch, which is dry, atrophic, loss of sweat is there. In Hansen's, sweat is lost because autonomic disturbance occurs. So you can always ask the child to actually go out, stand in the sun for some time and come back. And if you find that there is no sweating in that area, one can think of Hansen's disease. That's a simpler clue rather than going in for sensory examination. That's my personal take on that.
Thank you, sir. So I think we'll stop the question sessions for the time being, because if we keep on going for a long time. And first of all, I would like to thank Dr. Abhay Martin, sir, for this wonderful session. So it's actually eye-opening for all the pediatricians, because we generally tend to treat only with calamine lotion. So we need to learn beyond it. Thank you, sir. And I would also like to thank the IMA Kozhikode office bearers, Dr. Rakesh and Dr. Balram, sir, and our IMA CGP coordinators, Dr. Mithun Shashi, and Dr. Suresh sir is the chief coordinator, and also the senior members of our IAP Kozhikode and IAP Kerala, Dr. Vijay Kumar sir, our president-elect, Dr. Shaji Thomas John, past IAP president, and all the participants who participated with their wholehearted participation. So I would like to ask Dr. Ashraf sir, our scientific coordinator, to pass any comments if.
No more comments, Ajay. It was an excellent session, very useful for the practicing pediatricians, touching all the common practical issues. Really, it was a wonderful session, Dr. Abhay.
Thank you, sir. Just a big word of thank you for all the office bearers who have considered me good enough to be the opening batsman. I hope I've done justice to whatever I have done. Having said that, I was really touched because the number of participants had touched nearly 100, 99 or something at a particular point in time, which is
It was
amazing.
around 120.
It was around
It
120.
was 120.
It was around 120.
I'm extremely gratified that there's so much of interest in skin problems. Probably we should have systematic training sessions which will help pediatricians.
And very senior persons like Madhusudanan sir from Wayanad, TP Joseph sir, Balraj sir. So many senior persons were there.
Seniors are attending, definitely.
Thank you.
Shaji sir, the past IAP Kerala president. Sir, please unmute.
Okay, no. I was muted. No, I think it was Dr. Abe has lived up to the expectations. Thank you very much, Abe. That was really wonderful with a lot of.
Thank you.
Yes, I'm reminded of what Dr. Sugadan used to say, that instead of misusing steroids and other things, when in doubt, use plain calamine and wait out for the lesion to come up. But then I had a bad experience with calamine because I returned calamine once, and then the medical shop, which did not have calamine, gave Caladryl, and that was applied to the whole body. And within about 6 hours, the parents called me and said the child is drowsy. I didn't know what happened. So finally, I got the child admitted, and then only I realized it was Caladryl, which was given, which contained antihistamine. So we have to be very careful. Drugs can be absorbed from the pediatric skin much more than an adult. So that was a bad experience, but that is something which you have to be careful about. Another thing that you are bottling about not only soft moisturizing effect, that again, I think all of us can use freely without creating much of a problem, both calamine and soft compress or soft moisturizing agents. Now, just one thing about your stress on cotton gloves, I think that is very, very important, because a lot of people, as you said, are going on to semi-synthetic. At least cotton socks can be used. When we were students, we used to use cotton socks. That is totally out. And a lot of, as you mentioned, these track suits and others made of synthetic material, tight jeans, extra tight jeans, that again is a problem. I just one word about what is your opinion about the affluent malnutrition, which Professor Sugadan used to say?
Well, it is a term which can be used. It's a term which is the other end of malnutrition. We used to see people with vitamin deficiencies actually going in for, it's seen more often in kwashiorkor or in protein energy malnutrition. So we were taught how to recognize with the flag sign of the hair and the scaly lesions. So that was the other side where poverty was playing a role. Probably the seniors would remember how we used to be called into the wards and the caseless necklace and the scaly dermatose. The other extreme is where the child actually has access to all the nutrients. The parents are well-to-do. They are engaging the child very well. They are giving the child all available. They are after the children, 1 or 2 children that they have, they are after their children to feed. But the child just refuses to have nutrient substances. So as a result, what happens is the gut microbiome gets altered. So when the gut microbiome gets altered, you are likely to have occult storage of vitamin deficiencies coming up. So that is where you will have vitamin D deficiency, vitamin B12 deficiency, and the vitamin B1 or thiamine deficiency. So all of these are beneath the surface. They manifest many a time with cutaneous skin lesions. So pityriasis alba-like lesion may be a presentation of a vitamin deficiency. So, and even the atopics may be, the increase in number may be because of the altered dietary habits. So this is what is the concept of affluent malnutrition. You are affluent, you have everything available, but you are malnourished or improperly nourished due to reasons of we are bending down backwards to keep our children happy. So I think that somewhere we have to find a via media where there is between the carrot and the stick, there should be somewhere of a good call, a judgment call. So very often I tell the parents, it's your child. നിങ്ങൾ നന്നാക്കിയില്ലെങ്കിൽ കുട്ടികളെ നാട്ടുകാർ നന്നാക്കും. So because what happens ultimately, you have so many hypopigmented patches, the child goes in for a low confidence during around when the child comes into school age. So വെള്ളപ്പാണ്ടാണ് മാറ്റി നിർത്ത്, ഇല്ലെങ്കിൽ adolescent ആയിട്ടുള്ള ഏജിൽ they have body image disorders. So I explain them and I try to tell them, and then the child is actually convinced about it. So you have to engage the child in the conversation that it is his responsibility to look good, and therefore he should have vegetables and a balanced diet. So I take effort to explain that too.
Thank you. Thank you very much.
Thank you, sir. Thanks a lot.
Thank you, sir. So, Mohandas sir, shall we wind the session, because already around 10 o'clock
Yes.
now.
Vijaykumar,
Vijaykumar sir.
okay, stop.
Dr. Midun Shashi, shall we stop now?
Yes, we can stop now. It's already 10. Ajay, you can. Vote of thanks.
Okay. Thank you, Abhi sir, for the wonderful session. It was a very nice session and covered all the aspects of pediatric dermatology. Thank you, sir. Thank you all the other participants for your vibrant participation. Thank you. Good night.
Thank you, Dr.